our first speaker, our kickoff speaker, is actually, it's apropos that he's our starting speaker because Professor Thomas Stratmann has written more academic work on certificate of need than anyone in the field. And so it's really great that he's here today to share with us his perspectives on certificate of need and lets us understand where this came from, where we are, where we're going. He is a professor of economics and law at George Mason University. He's a scholar at the Mercatus Center at George Mason University and has published in major political and economic publications in this country. He was educated in Berlin. He received his PhD from Maryland in economics, and most of the things that I know about certificate of need, I know because I've read his work. So without any further ado, please let's get the meeting started, and let me introduce Professor Thomas Stratmann. Reach under here, get that.
Do we have a PowerPoint here?
We have PowerPoint. Is there? Let's see. I'm sorry, I was negligent. This is probably it. I think that this should.
Yep, that's it.
That's it.
Is it big enough? Okay. And move it over here.
Let's see. So there's the screen.
How do I move this forward?
Let's try this. Okay, can we get the person? I'm so sorry.
It's okay. Better now than later.
Yes, absolutely. Okay, well, I should have been better prepared. And then it's this?
Okay.
Perfect. Thank you.
Morning. As Hal said, I'm Thomas Stratmann. I'm a scholar at the Mercatus Center at George Mason University. And I would like to thank Hal for the generous introduction. I'd like to thank you for organizing this conference. I'd like to thank Heritage for hosting the conference. And I'd like to thank all of you for participating and attending in today's conference. It's going to be great. So, that being said, 50,000. What does this number mean to you? Does it mean to you the number of people perhaps in your hometown where you grew up? Does it mean to you perhaps the number of people in a baseball game? Today I'm here to tell you what this number should mean to you today. 50,000 is the number of people who died last year from colon cancer. And 50,000 is going to be the likely number of people who are going to die from colon cancer in 2017. This is tragic. Why? Because colon cancer is highly preventable. It's highly preventable if it is detected early. How can we detect it early? Well, by screening at the beginning of perhaps age 50, as recommended by many medical experts. Screening helps us, or helps the doctor to detect precancerous polyps early, so that they can be removed and never turn into full-blown colon cancer. So why is it that not more people are getting screened, so we can really significantly reduce this 50,000 number? Well, you can probably guess why. It's because optical colonoscopy, which is typically used for screening, is unpleasant, it's invasive, and it's also risky. Thankfully, there is a simple solution out there. And this simple solution is virtual colonoscopy. Virtual colonoscopy involves putting the patient into a CT scanner, which is a glorified X-ray machine, and then the doctor obtains a three-dimensional image, which allows the doctor to identify precancerous polyps, which then can be removed if they're there. And because virtual colonoscopy is so non-invasive, it has many fans. For example, former President Obama used virtual colonoscopy when he got his comprehensive exams. Which takes us to the question, if virtual colonoscopy is so non-invasive, much, much better, actually also cheaper, why is it not the case that more people are using that service? So we identified the culprit. The culprit are state regulations that limit the ability of healthcare providers to offer cost-effective and innovative healthcare, like virtual colonoscopy. These regulations require that healthcare providers first have to obtain permission from state bureaucrats before offering services like virtual colonoscopy. So the culprits are certificate of need laws, or as I refer to them simply as CON laws, which require that state agency approval has to happen before an already licensed provider can establish or expand a new healthcare facility. It turns out that 36 states have CON laws, including Washington, D.C. In 36 states, it's illegal to open a medical facility or even to purchase certain types of medical equipment without special permission from state regulators. Importantly, these certificate of need laws have no public health justification. Separate state and federal laws and regulations guide what qualifications are required for physicians to treat patients and to operate on them. Going back to virtual colonoscopy, CON laws prevent doctors to purchase CT scanners to offer virtual colonoscopy. And an example of a person who tried to offer virtual colonoscopy and was denied is Dr. Monteferrante and his partner, Dr. Baumhol. They wanted to offer virtual colonoscopy in the state of Virginia. However, Virginia has one of the most restrictive CON laws in the country, and Virginia also has a CON law specifically for CT scanners, limiting the ability of providers to purchase a CT scanner. So in Mark's case, the bureaucrats in Richmond decided there was no need for virtual colonoscopy, and they denied his application. So CON laws empower state officials to determine what healthcare services are needed. CON laws say state officials are in a better position to determine need than doctors and patients are. Mark teamed up with a team of lawyers from the Institute of Justice to fight this in court, and I look forward to hearing more from the Institute of Justice later today. But CON laws actually have even a bigger problem associated with it than just that there is no permission perhaps for some providers to provide innovative services, new services. In 2012, a pregnant woman arrived at Lewis Gale Medical Center in Salem, Virginia. She was, as I said, pregnant, and she was bleeding, suffering from a condition that triggers premature birth. This condition can be fatal for both the mother and the baby. Lewis Gale did not happen to have a neonatal facility to treat the mother. So they contacted a nearby hospital that had such a facility, but that nearby hospital was unable to dispatch the special ambulance needed because the ambulance was used otherwise. So no ambulance arrived to treat the mother and to send her to a different hospital. Lewis Gale was able to save the mother, but the baby tragically died. So the infant did not just simply die because of medical complications, but also because Lewis Gale did not have the neonatal services necessary that would have given the baby a better chance of survival. And Lewis Gale was simply not equipped. And why was he not equipped to have these services? Why did Lewis Gale not have these medical services? Because the bureaucrats in Richmond repeatedly denied applications from Lewis Gale to have a neonatal service unit in their hospital. Adding to this injustice is that when the bureaucrats in Richmond decided not to grant the CON application for an 8-bed neonatal specialty care unit to Lewisdale, these bureaucrats acted in accordance with the wishes of the main competitor of Lewisdale. So another hospital that was competing with Lewisdale regarding services opposed Lewisdale's application, and the bureaucrats followed the competitor's wishes. So how did we get here? How did we get to a situation where we have such, quote unquote, I would call them bad laws? Well, it started in 1964 when New York was the first state to introduce CON laws, or Corn Law. Then in 1974, the federal government followed and incentivized states to adopt Corn laws, and it did so, as it often does, by tying federal funds. So if you didn't adopt Corn Law, you will not get a federal fund. All states followed suit, except Louisiana, and by the early 1980s, all states, again except Louisiana, had this law. However, so the idea of this law was, if we have corn, maybe we can restrain the increase in healthcare cost. That was the motivator. The other motivator was, well, if we restrict suppliers, then maybe they get more profit and they can provide more indigent care to the poor. And so, however, by the mid-1980s, it turned out that the federal government realized there are no cost savings. Corn doesn't help us at all. So they repealed the federal law. And subsequently, about 15 states decided to get rid of the Corn Law. So now we are with about 36 states still having corn laws. So let's look at the map over here of states that have corn laws. You see they are mostly concentrated on the east, southeast, and also somewhat in the northwest. So actually, I'm curious, who of you guys are living in a corn state or have a friend living in a corn state? Oh, almost everybody. That's why you're here. So that probably means that you have a personal stake in this issue. Now, the corn laws come in different varieties. They're not all the same. And to give you a sense of that, it's just sort of the following map, which is really hard to see, but it just sort of ranks the state in terms of the number of different medical services they're restricting in terms of which you have to get a permission. The top row actually stands for Vermont, that has 32 different corn regulations, and this is followed by states like DC, well, the District of Columbia, Hawaii, North Carolina, and Maine. On average, states that have corn laws, they restrict about 14 different services. So to give you a sense what kind of services are being restricted, one example is the medical offices. So only 2 states restrict the medical offices, meaning they have to get a permission to open a medical office. So that's perhaps not so bad, only 2. Ultrasound is restricted by 4 states, just simply providing getting the equipment to provide an ultrasound. Again, this is sort of at the lower end in terms of where the fewest restrictions are. Let's move to an area where we see many more restrictions, or that are much more widely restricted, which is cardiac catheterization. 26 states prevent a doctor to offer cardiac catheterization, even though they are qualified. So it's just the machines. It's not an issue of them being qualified. Then let's look at ambulatory surgery centers. ambulatory surgery centers provide outpatient care for surgeries, and usually staying at them is often a little bit more pleasant than staying at a state hospital. It turns out that 27 states basically restrict the opening of ambulatory surgery centers. And the last example are hospital beds. Imagine that. Hospital beds are being regulated by CON, meaning a hospital has to ask for permission to add another bed. So it does not perhaps have to turn away another patient. It turns out 28 states limit the ability of hospitals to add a bed without asking for regulator permission. So let's go back and see why these laws are in effect, meaning what are the claimed benefits? What do the hospital associations and others who are saying we should have CON laws, what do they argue? They argue that it assures the supply of health care. It also gets more access to rural communities, they argue. The quality of care, for some reason, I'll go to that a little bit later, quality of care is miraculously higher when we have CON. Going back, then the argument is, well, we also have more charity care, and the costs are going to be restrained. So all these wonderful things are supposed to happen with CON. So given these benefits, we at Mercatus decided to take actually a look at the data and see if these benefits hold up. But before talking about our studies, let me talk briefly about one more aspect that informs us how CON laws are supposed to work. What is the mechanism by which CON restricts competition, as it is intended to be? So let me give you some detail through what kind of hoops a medical provider has to jump through in order to provide services, assuming the provider operates in a CON state. So every state, or all states are different in terms of the different specific procedures, how to apply for a CON, who exactly decides, so on and so forth. But in general, this is the following pattern. First, a letter of intent is being filed, and then if they're getting some feedback, they're going to do a full-blown application, which can be up to $45,000. That's just the application fee. We're not talking about lawyers' fees, which are coming on top later on. Then there's going to be a public hearing. And here, imagine this, established hospitals and medical providers, established medical providers, they can oppose the application of the would-be competitor. This is the same as if McDonald's would oppose the opening of a Burger King in the same state. So this is the way the CON system here works. And then finally, there is some fact-finding by a conference or a committee that decides whether to approve or not to approve. So this process can be 6 months, can be several years, and often this process verges on a full-blown litigation, especially when you have incumbent providers opposing the application. This process is a little bit like optical colonoscopy. It's unpleasant, and it's also risky because you put up money, and you don't really know whether your application is going to be approved. So, and another aspect in this whole thing, and we're going to come back to that briefly at the end, is that the entire process is not transparent. It is really not clear on what basis bureaucrats decide whether a service is needed or is not needed. They have some general plans, but again, there's nothing specific that would inform an applicant, this means I get approved, or this means I do not get approved. No clear criteria, which opens, of course, up the entire process to potential fraud. So who are the winners? The winners are clearly the established hospitals. Those hospitals and providers that have a certificate of need, because they hold essentially a monopoly, because more barriers cons are restrictions to entry. And the losers are the innovators, like Mr. Monteferrenti I mentioned, people who want to provide new services. And also the losers are the patients, because they are not getting the services they might want to have. They don't have even the option to get these services, because the option is not being provided. Now, so one way to think of certificate of need is it's a government permission slip to compete. This is because, again, healthcare providers have to ask state bureaucrats for permission. Now, our approach at Mercatus has been to test all the different claims I listed earlier regarding certificate of need laws. Do they improve more quality? Do they provide access to more access to for the people living in the rural communities? Do we see more charity care? Do we see more supply of medical services? So to do this, we conducted some national studies, including all 50 states and the District of Columbia. And by necessity, they're going to be all the 50 states. It's going to be national because we're going to compare states without con laws to states with con laws. And because this comparison will give us some insight into what would happen were a state to repeal its con laws. And then we're going to take these numbers and we're going to apply them to individual states, because we have the data for the individual states. From the national studies, we arrive to conclusions, but we can back out from these national studies what these numbers mean for each of the states that have certificate of need laws. So just to give you a brief summary, and I'll talk about some numbers in a second, but the data we have always seem to suggest the promise made by proponents of certificate of need laws, one, does not hold. And even worse, it backfires. It goes in the opposite direction. So one thing we might have found is con states have as many rural providers as non-con states. And again, that already would have flown into the face of proponents, because we do not see more provision in con states. However, we find the opposite. We find that in con states, we have fewer medical inputs, fewer medical providers. We see less utilization of medical services, as measured perhaps by MRI scans and CT scans. We see reduced access to care. And moreover, we see reduced quality of medical services, something I'll talk about in a second. So things are not better in con states. Things are worse in con states. Now, let's talk about some quick numbers to give you a sense of what we're talking about the magnitude, how much worse are things in con states. Let's look at the number of hospital beds. So it turns out that states with a con law have about 27% fewer hospital beds. What does this mean? This means on average, per 100,000 population, these states have 99 fewer hospital beds. Comes back to the numbers. So it's per population, not per patient. So this seems already like quite a large number. Also then, if we look at hospitals with MRI services per 500,000 population, there we find that 35% fewer provision of MRI services. So 35% of hospitals there are fewer hospitals by 35% in terms of the provision of MRI services. What does this mean? In a town on average, in a town of about 500,000, in a state without con, there are about 6 MRI machines. In a similar town, with con, there would be 4 MRI machines, so 30% less. We also find the same with CT scanners, significantly fewer CT scanners in states with CON laws. Now, let's go back to the other claim, which is CON provides more charity care. So the idea is we're going to give these hospitals a little monopoly. Monopoly means you're going to get excess profits. And so the hope is that, or actually it's in the application they write, that they will provide extra charity care. So we compare charity care in states with CON versus non-CON. What do you think we found? Do we have 10% more charity care in CON states? 5%? Well, it's 0. The hospital in states with CON provide just as much charity care as states without. So no benefit of CON in terms of additional charity care. Now, let me briefly explain to you how we apply these numbers and some other numbers, which I have not talked about, to individual states. Michigan is a state that has a CON law, a fairly restrictive CON law. So we have been trying to let states know what CON means for them and how the world might look like if they were to repeal the CON law. So here is an example. So basically going back over here in yellow is Michigan without a certificate of need law. In blue is the current situation, Michigan with the certificate of need law. So what we see currently, there are 171 hospitals in Michigan. In a comparable state to Michigan, a statistically comparable state, without a CON law, there are 243 hospitals. Again, next thing, look at ambulatory surgery centers. Currently, Michigan has 91 ambulatory surgery centers. States similar to Michigan have 106 ambulatory surgery centers. So these numbers, these last two slides, go to the fact that more provision of medical services, more choice is available when a state does not have a CON law. Let's go to the claim of rural provision. So remember, the idea is CON is good because it increases rural provision of medical services. The idea is the regulator is going to keep the ambulatory surgery centers out that are doing all the cherry picking, as it's referred to, or cream skimming, taking all the profitable patients from the hospitals, and therefore the hospitals have a better chance of surviving in rural areas. Now, when I look at the numbers, I see, well, currently Michigan has 58 hospitals. In states comparable to Michigan, they have 83 hospitals in rural areas. So again, we find more provision of medical services, even in the rural areas. And same with ambulatory surgery centers. Right now, Michigan has 6. In comparable states, they would have 7. So it's about a 15% increase. Now, let's look at non-hospitals. So to what extent does CON affect non-hospital providers, so doctors? And we're looking here specifically at MRI scans. So do we find more MRI scans, more utilization in states with CON laws or without CON laws? Well, consistent with the other numbers we have seen, Michigan currently has about 45,000 or so MRI scans per year. Comparable states have almost 70,000 MRI scans per year by non-hospital providers. This tells me there's more provision of medical care in states without CON laws. Same with CT scans. Again, many more CT scans are being provided in states and demanded in states with CON law, without CON laws than in states with CON laws. And this is just the same number for PET scans. It's kind of tiny on top. Again, same pattern as before. Now, let's address the issue of quality of medical services. So the idea is, CON proponents would argue, well, we're going to restrict supply. This means that the doctors are going to be more busy. They're going to do more operations because we have fewer hospitals. More people go to these fewer hospitals. more operations, so the doctors are becoming more skilled. And so medical services are going to improve just because they have more, doctors have more experience. Well, that's one possible story. Another story is, well, if we have less competition among hospitals, well, how does this less competition play out? Hospitals can compete somewhat on prices, but not that much, given that many of the prices are set by Medicare and Medicaid. But one way hospitals can compete is on quality of services. Quality of service is certainly one dimension in which hospitals can compete. And so, which reminds me actually about the, if you think about how competition is good, think about the old monopoly of AT&T, where you had to wait for 2 weeks or 2 weeks to get a landline installed. So, meaning that competition will tend to improve quality of services, as we've seen in other areas. So this is certainly another way in which corn potentially can be harmful. Again, we looked at the data to test whether quality differs between corn states and non-corn states. And so we looked at several things, and I'm just going to some highlights. We looked at mortality rates from pneumonia, deaths from among surgical patients with serious complications, heart failure, and heart attack. So what we found was actually stunning. One thing is, first of all, quality is not better in CON states. That's number one. But even much more concerning is that quality actually in CON states is worse. We find, for example, a 5% higher mortality rate from pneumonia in hospitals in CON state. 2 to 3% increase in mortality from heart attacks. And so this tells us that quality is definitely not getting better in CON states. If anything, it is worse. So there doesn't seem to be too much to the story that doctors are getting better by just simply operating more often. Now, lastly, let me talk about one more issue, which relates a little bit to the point when I said, well, the rules of the games are very vague, meaning what is need is really vague. Corn laws invite basically the gaming of the system, if you want to put it like that. We know that hospitals or corn provider, or whoever has a corn, they have excess profits because they have a little monopoly. And so certainly everybody likes to have a corn. There's going to be competition to have a corn. So how is this competition going to play out? Well, most people are going to use legal means, but some firms may result to using illegal means. And there is actually evidence on corruption that went to court, and where the court found corruption on the corn issue in Alabama and Illinois, where the bribes were being paid to get someone on the board of a corn committee, or a bribe being paid to have a certain application approved. So let's look at. So I looked at Georgia as in some other states, but I'm just going to use Georgia as this example right now, not to pick on Georgia. So so we want to see, well, how about what is the political activity of people who apply for a certificate of need law versus those who do not apply? So we looked at contributions to legislators, campaign contributions to legislators. On the right-hand side, you see contributions of corn applicants. On the left-hand side, you can see contributions of non-applicants. So you see that applicants are much more politically active, which, by itself may not mean a whole lot, but it certainly tells you that they are investing resources into the political process. Then I just looked at applicants by itself, and I've looked at, do applicants who give more contributions to legislators, are those more likely to be approved? Because there are stories out there that legislators are picking up the phone, calling the regulator and say, hey, take a look at this application. He's in my district, or she's in my district. Can you maybe be favorable? So here you see contributions and the approval rates. So in blue, you see the approval rates, and the approval rates are much higher on the right-hand side of people who contributed versus those who did not contribute. And conversely denied, if you look at these numbers, people who did not contribute were much more often denied. So again, this is not to say, this certainly raises the flag, and it is corruption. It is consistent with a bunch of corruption evidence that has been dug up by courts. Now, finally, let's look at how the world might look like if we would have not a con. And for that, we compared 3 states. We are comparing Virginia, that has a CON law, to Pennsylvania, that repealed its CON law in 1990, and Ohio, which only has a CON law for nursing homes. And the reason we compared these 3 states is because they are roughly similar. All of these 3 states have basically 2 urban centers and otherwise large urban populations. So actually, the Virginia Hospital Association, they take the number from Pennsylvania, which is on top, the red number, and say, well, see what happened after 1990. All these, they have much fewer hospitals than before. That's what the talking point is to the legislature. But when I compare Virginia to Ohio and Pennsylvania, I see that in Virginia, the number of hospitals dropped by far more. So Virginia is actually, there was a downward trend in hospitals over time. We know about that. But the downward trend is much more pronounced in CON states than in non-CON states. So this tells you that we have more medical provision when we do not have CON. And lastly, for ambulatory surgery centers, in the 1990s, they were not very popular. And look at the growth rates of ambulatory surgery centers in Ohio and Pennsylvania versus Virginia. Much more growth of ambulatory surgery centers. In Ohio and Pennsylvania that do not have CON laws. So this tells us no CON means more provision of medical service, more innovation. I again like to thank Hal for inviting me, and it has been a pleasure talking to you. Thank you.
That was great, Thomas. Stick around for just a second. We have a little bit of flexibility, and would you want to take a couple of questions if there are?
Definitely.
And I've gotten a couple of texts. I'm tweeting as we go and trying to get this out there. Your talk was excellent, incredible, informative. People want to know if we can share this with everybody here.
Yeah.
Okay, so that's something that we will make available to anybody who gets in touch with us. Yes.
Really neat. The mortality data is stunning. And I'm just curious what other variables might be involved in that, and what would your hospital association say when you showed them that?
So basically, the way we designed this, it was a very sort of careful design. We considered basically certain areas that were very similar, like these health referral regions from the Dartmouth Atlas. And some of these health referral regions they are covering 2 sides of a state, a con state and a non-con state. So we looked within specific regions. Part of the region is con, part of it is not con. And we compared basically the quality ratings of hospitals, or their quality numbers in terms of mortality. So basically, the goal was to do an apples to apples comparison, to have basically looking at areas where the socioeconomic characteristics of the patients are sort of the same on both sides of the states. And what the hospital association said is, well, you didn't really control for enough variables.
Sure.
So that was basically that was their take.
I have one question. I'll take moderator prerogative. Thank you for picking on Georgia. I really appreciate that. But one of the questions that I think is important to answer is not new entrants into the CON process, but those who are entrenched interests and the continued contribution of those who are profiting from that. Has that been looked at?
The
Existing hospitals, for example, the contributions that they make to the political process, those who are in control of the CON process.
not not that I know of. In part, this covers it because lots of the existing hospitals, they often apply for some expansions, something like that.
I see.
So they are basically in the data already, and they are the ones who get approved.
That makes sense. Last question.
This slide is something you didn't mention on this slide is surgery centers, ambulatory surgery centers are a much cheaper place, a much more cost-effective place, a much higher quality place for surgery to occur.
Mm-hmm.
So this trend would also correlate to decreased healthcare costs, healthcare expenditures in this last slide. But I think that the ultimate message here in our country that is limited to 144 characters per thought is that CON kills, and that I found that very impressive in your slide.
Thank you very much. Yes, it's one issue is that you're right with the fact that ASCs are much cheaper, tend to be more efficient, more pleasant, and so it shows that no CON is going to lead to more innovation. And I also completely agree that the CON kills message is very powerful because this brings it to a very different level as opposed to fighting over numbers.
That's a good tweet message to get out right now. CON kills. Thomas, thank you so much.
Thanks so much.
Great.
I appreciate it.